This podcast continues with Chapter 20, Musculoskeletal Injuries. We want to look at assessment of specific injuries, and in this case, those of the upper extremity. So we'll start at the top. The clavicle is what we commonly refer to as the collarbone. Now, at one end, the clavicle is joined to the sternum, the breastbone, and we have the sternoclavicular joint. At the other end, the clavicle is joined to the acromion process near the top of the shoulder, and we have the AC joint. The clavicle is the most frequently fractured bone in the body, most often right in the center or at the distal portion where it's narrow. It can be quite painful, and typically a patient will present by hugging their arm to their chest, trying to minimize any movement. Now, what we may see at a fractured clavicle is a little bit of tenting or bridging in the skin and an obvious deformity. If you went to palpate, basically trace your fingers along that clavicle line, you're going to have quite a bit of tenderness and pain at that point. Now, the distal end of the clavicle is where we join to the acromion process. That is the AC joint, acromioclavicular joint. Now, that can be, like all joints, dislocated. That will happen if you fall on the point of the shoulder and affect that joint. We can call that an AC separation or a shoulder separation. It is not a fracture of the far part of the clavicle, and it is not a dislocated shoulder. It's a dislocation, but we call it a separation. Now, again, we'll have tenderness at that AC joint, and we may have a little bit of a deformity there because those two bones have been displaced. But keep in mind that AC separation is much different from a true shoulder dislocation. A skier who falls forward, a biker who goes OTB is likely to end up with this injury. Now, the shoulder itself can dislocate. This is much more serious. That ball and socket joint at the top of the humerus is designed for motion in 3 dimensions. Consequently, the ligaments there provide lots of range of motion. They're not very strong. Now, if a shoulder dislocation occurs, 95% of the time, the humerus is going to come out of the socket and end up in front of where it should normally be. Only 5% of the time will it dislocate posteriorly. Now, the mechanism for that is going to be abduction, moving the humerus away from the body, and rotation. If that happens, sometimes the most pain-free position for the patient is to just keep their arm in that position. If you think about how this can occur, think about a kayaker making a big, wide power stroke, and then consequently wanting to stay in that position to avoid any pain. Okay, we'll see that they may want to hold that away from the body. We may see a dent at that location, and they're going to be in a considerable amount of pain, and they likely will have some numbness on the outside of the shoulder due to disruption of the nerves in the joint. Now, it's very rare that we'll get a posterior shoulder dislocation. This might commonly occur in a motor vehicle accident if someone puts their arm out, or very rarely if someone was to lock their arm during a fall when they put their hand out to protect themselves. Now, scapula fracture is also a rare injury. Think about that large triangular bone at the back of your shoulder that you can palpate or feel through your back. That is a huge bone. If that injury occurs, it's due to a pretty severe mechanism of injury. You're going to have in that zone of injury also injuries possibly to the spine, maybe even all the way through to the chest wall, and so on. Very, very, very serious injury if this occurs. Now, the long bone in the upper arm is the humerus, And close to the upper end of that, what we would say is the proximal end, you can break the ball that would fit into the shoulder joint, or where the bone narrows just below the ball, you can have a fracture in the neck of the humerus right there. Pain is going to be very common, and because of the biceps and the triceps being concentrated at that upper end of the humerus, sometimes it's very difficult to palpate or feel. Now, that humeral shaft fracture could be pretty common. It's going to be pretty tender, and we can get some deviation from straight between shoulder and elbow because of the strong muscles around the bone contracting and displacing the bone ends. Significant angulation could occur, and we also may have some loss of motor function due to nerves being compromised in that fracture. If we move a little bit further down, we can describe some elbow injuries, and there's several different types. Now, if you think about the normal articulation of this particular joint, you can imagine some of the presentations being very deformed depending on that injury, and also some loss of motor function or sensation due to compromising the nerves that pass through the elbow. All elbow injuries should require you to contact EMS and transport that patient. Permanent damage can occur. Now, let's focus on just the upper end of that elbow area, a distal humerus fracture. You can have a fracture in the far part, the distant or distal part of the humerus, again, as up above, where the bone is very narrow. Now, we call that a supracondylar fracture. A condyle is that big knobby end on the end of a bone. And if I'm above that, that's why we call it supracondylar fracture. It can have some complications if it occurs, especially in children, again, because of disruption to nerves and blood vessels that are there. Signs and symptoms, a lot of pain and deformity as the strong muscle structures above pull that out of alignment. If we have an elbow injury to the olecranon, this is essentially, if we take this apart, ole means elbow, and cranon, similar to cranium, the head. So the head of one of the lower bones, where the radius fits into a little bit of a hole at the end of the humerus, you can end up with a gap in between there. And because of that fracture, the patient's not going to be able to extend their arm. If I get a fracture of the radius, the larger bone in the lower arm, that can occur because of a force in which the lower arm is forced into the upper arm, the distal end of the humerus. This could happen by falling on an outstretched hand. Movement, think about the rotation that your forearm allows. Pronation and supination is going to be very painful. Now, an elbow dislocation, as we see in this x-ray, is a specific type of injury. And in this case, we're going to see displacement of the bones from the joint, and consequently, it's going to become locked. Pain is very severe, and the circulation and motor function and sensation are going to be very compromised. Anything below this dislocation is likely to become numb and no ability for movement. Now, specific type of dislocation that occur, especially in pediatric patients, is something called nursemaid's elbow. And that happens if a child's hand gets jerked, or, a game that parents often play, swinging a young child by the hands. It's going to be very painful for the child, and you can expect them to be guarding that injury by holding the arm close against the body. Now, specific forearm injuries You have long bones in the forearm, the radius and the ulna, and they can fracture just from a direct fall as well. We see here a snowboarder catching a toe edge, putting their arms out to catch their fall, and you can imagine the force that's going to end up on the bones of the forearm. Now, if both bones are fractured, you can imagine that you're going to end up with some false movement that shouldn't normally occur anatomically. We see the change from anatomical position that we see right there. Now, at the distal part of the radius or the ulna, we end up with a silver fork fracture. If you imagine a very fancy fork and the bend that you would have at the head of the fork from the handle, we see, rather than the forearm being straight, that curve that's there, it's just the name of a particular type of fracture. Moving more distally into the wrist, one of the major bones that we find in the carpal bones of the wrist is the scaphoid. A fracture to the scaphoid can happen, again, from a fall. Think about a snowboarder catching a toe edge. And we have this normal depression that might occur here. We call it the anatomic snuff box. And that's the location of the scaphoid, and that's the location of that carpal bone that can fracture. We see it in this anatomical diagram right here. It's this triangular bone right at the base of the hand, very prominent in the wrist. Skier's thumb is a sprain of the ulnar collateral ligament. You can imagine catching a ski pole or skiing through trees, or sometimes falling. And we see the characteristic presentation as shown in the photo. Hand and finger injuries can occur as well. Could be a fracture, could be a dislocation. In any case, you can expect pain and swelling and some loss of motion in all of those injuries. Now, we have in Chapter 20 a way to assess neurological function of the three nerves in the hand. The median nerve is that nerve that allows us to flex the fingers, close our fist, and where that location of the sensation is going to be on the palmar side of the thumb. The opposite of that, the radial nerve, allows for extension or opening of the hand. And if you look at the palm side of the fifth finger, some numbness there may indicate compromise to the radial nerve. And if we were to open our hand wide, spread the fingers apart, inability to do that may indicate compromise to the ulnar nerve. The final injury to take a look at is one that's pretty extreme, and that could be amputation of a hand or a finger. We can expect that in a winter environment, as described here. Imagine someone improperly trying to remove an object in a snowblower and reaching inside. Very dangerous. In this podcast, we looked at some particular upper extremity injuries and how they may present. We'll move on to treatment of those injuries in the next podcast.